There's got to be. So it takes a minute to get everything situated, but should be back on the plan to get us rolling and moving along. I kind of want to start just to remind everybody that boot camps are coming up again. I don't have the date in front of me, but please make sure that you are studying your NREMT handouts that I posted on here, that you know those left, right, and forward and backwards. If you get to a point to where you have some concerns or questions on certain topics, some skills, please make sure you make notes. So when you go to these skills, let's hound down those skills and the actions on how to get those taken care of and the knowledge of it. So when you do get more focused on your National Registry skills, that we can kind of tailor these boot camps to fit everybody. Again, I'm going to try my best to make it to one of these boot camps. I'm not really sure because I know we handle them all over. I probably won't get to meet all you guys, but I'm sure some point in time in your life you'll hear my voice again and be like, ah, it's that guy. But moving right along. So tonight is Neurologic Emergencies. My computer never clicks right every time I want to hit it. So we know we talked about the competencies that we have to talk about. If you notice, they really hadn't been, they're all the same. I kind of get tired of them. So after a while, I just keep hitting the button because I'm tired of seeing them. Throughout tonight, we'll talk about decrease of levels of responsiveness, seizures, and stroke. We'll go into depth of the patho and the patho and physio management on how we're going to take care of these stroke seizure patients. What is true status epilepticus? And you have ever been around EMS long enough, you will get a call for that last one. And it really only takes about a call about 2:30 in the morning when you really hadn't had any sleep and you're thinking, why in the hell can't you get in one of your 8 cars in the front yard and go to the hospital and because of your headache? But that's part of life. It's our job to take care of sick people and then the worst, and that is an emergency for them. So that's why we're there. So we'll talk more about the strokes. We're going to hit strokes and seizures to begin with. So stroke is the 5th leading cause of death in the United States of adults of disabilities in the United States. So what is the number one? Can y'all remember what the number one death is caused by in the United States? Oh, so Rebecca, the first boot camp, September 11th. Let's see if I'm home. Oh boy, I am home. But no, I will not be at that boot camp because I will be in Nashville that weekend. So correct, it is heart attack. But back to the boot camp thing. No, I will not make it to any boot camps unless there is one in the Nashville area. My sister-in-law just had a COVID birth, so we have to make our way up there to see this baby that was born 5 weeks early and didn't require to be put in a incubator or anything like that. So we're gonna go see them. So most of your strokes do kind of partake into the geriatrics. That is your elderly bunch. If you're not familiar with what associated with the geriatrics, but that is where majority of these do take place. It's not saying that you can't have them when you're younger, but it is due to like the clots and everything that's moving around, and the vessels are a little bit caked over, so they do have stroke. A lot of your contributing factors are if they're pretty predominant in your family. A couple other people have had them. There are things you can do to help reduce that if they are pretty big in your family. But again, they're pretty bad. They do have new treatments out there like the clot busters. You can be at a stroke facility and with so long, and they can reverse these. But again, it depends on what part of the country you're from. If you in a pretty rural area and your stroke facility is far enough, you may have to fly that patient. But recognizing of the stroke and following your stroke protocols for your state may be a little different than what we do in Mississippi. Central Mississippi, we have one facility that takes these patients. They're pretty quick on doing it. A lot of times we use this app called Pulsera. We can activate a stroke by using the app, or we can also turn around and pick up the phone and call in and activate the stroke. So basically what you're doing is you're kind of taking a speed line through the ER because they know that these patients only have certain amount of time that is available before that the stroke can be reversed. So, and if you have to, depending on where you're from, you may have to fly them. So if you know it's a hour and a half by ground, it should only be about 30-40 minutes by air. So depending on your location, the benefits of them flying is going to be the best thing that you can do for them. So recognizing is the best part. So seizures, altered mental status may occur. Seizures may result due to prior head injuries, let's say a traumatic event, like a pretty bad car wreck. They have the coup contre coup effect, and now that they have a head injury, they could go into a seizure on the way into the facility, on the way transporting into your medical facility. Brain tumors, metabolic problems, high fever in children can cause these, and then genetic disposition. So they may be born with something that causes that always triggers it. And if they're young at that point in age, they have to find the correct dosage. They have to find what medicine works. So it is a very lengthy process to get these seizures to stop, slow down. You see a lot of vets that have these due to traumatic brain injuries from being being in a explosion or other traumatic injuries. And they live with a debilitating process. I'm real big on natural medicine. You can take that however you want it for seizures. I've seen it work very well. So upon that, I wish that we could get those out there a little bit more. Some people have to move to receive the natural medicine due to some of your state laws and all that. So you got to do what's best for you, folks. Possible causes of altered mental statuses may be intoxication, head injuries, hypoxia, stroke, metabolic disturbances. And when we say that, think about your diabetic patients. So your diabetic patient is going to present at the same time in a late situation as same as a intoxicated substance. So if you're on the ambulance and you go out to this intoxicated substance person, but you just can't figure out why, maybe check their sugar. See what the sugar shows you. Could show you some different issues into where they could be hyper or hypo, and that's an easy treat. You can fix that. So the brain body controls these things. So, sorry, my headphones are falling out of my ears for some reason. That's what I was trying to adjust. All right. So it controls breathing, speech, and all the body functions. We talked about that. That is an involuntary process. Let me see what Rebecca says. What natural medicine will help with seizures? Just out of curiosity. I know CBO can help people and animals. Is there anything else? Yes. So I'll take my teacher cap off. Here, look, hold on. Let me fix this. All right, you have to excuse my hair and my appearance, but I will tell you. So I have physically seen it. Natural marijuana will help that also. A lot of patients will move due to location. The THC is what helps calm that down. So what we try to do is, like, I've actually had several people I worked with in different parts of the world have had to move to these places to where it's legal, to where they can get prescribed that. The correct dosages vary, depends upon the injury. It depends upon the tolerance, obviously will build, but marijuana does have several good causes. It's a pain medication at the same time when it's used correctly. My mom had cancer. Radiation hurt her really bad. She partaked in a little bit of the natural medication. The first time I ever saw my mom eat after she started cancer was after that, which was great. and it kind of helps with pain. So the seizures do stop with that THC, is what you've seen before. If you see some of these documentaries on the kids, they do take the CBD oil, flash the THC, and then stick it in their mouth, and within a couple of seconds, it helps. They also have seen this documented in Parkinson's patients. So there's several things that are out there. I personally believe you won't see this as a FDA approval drug because the federal government really does not know how to tax that when it's something that's natural. It's grown in the wild. It can be situated, but if you'll do a little bit of the reading and investigation, is a lot of the states that take that as legalized, they can't put it in banks. So, because it's FDIC, it's federally reimbursed. So it's federally insured. So they have to be cautious of that. There's a lot of cash in those states. So what weed does have its benefits. That's outside of my teaching skills to teach that, because it's not right. It's not FDA approved. It's not what you should do. Again, there are a lot of medications that we use on a day-to-day basis that's not FDA approved, that's prescribed, that I carried in my pocket for 20 years as a paramedic. Can anybody guess what medication is not FDA approved that is on a lot of your ambulances across the country? Anybody want to guess?
I have no idea.
I'll give you an. Okay, well, it's a pain medicine. How about that? Anybody? So morphine is not FDA approved. We use it every day for pain medicine. It does have a high tolerance, a high addiction rate, but again, that's part of it. It's not an FDA approved drug. Kind of crazy, but guess what? It's out there. It's an antiemetic too. I do research there. See, Rose probably, you can tell us a whole lot more than I can. I'm a believer in it. When I was a peace officer, I didn't take everybody to jail because they had a little bit of weed on them, but at the same time, gotta be smart about it. Rose, if you have anything you want to add in on there, please feel free to. I'm not trying to put you on the spot, but you can definitely teach us something if you have any information. All right. So I'll keep moving on. I'll leave my camera on tonight. Sorry, y'all got to look at that. I just didn't do my hair. If I get fidgety, that's just how I stay awake doing all this. So we talked about the brain before, different parts of the brain, the cerebellum, the skull, the brainstem, you probably should understand where these parts are, is when you get into this and you start looking at your pieces and parts. It is the oil field life. It's long sleeve hot shirts all day, and you're just like, oh my God, it's hot. It was 111 when we landed here at 10 o'clock this morning. So if you can see, the spinal cord is wrapped up in here as it comes through. We know it's wrapped throughout the spinal cord. So all your central nerves, your little nerve endings, and it's all encased into your spine. It's all the way up into your neck, which is the most vulnerable part of the spinal cord, is right at the neck and to the shoulders, because that's where it's the least protected. This is just a pretty good idea, so you know which particular parts are located where. Whew. I've been up since 2 o'clock this morning, also couldn't sleep. So the brainstem controls most of the basic functions. We've talked about this before. The body does not have to think when it makes these things. It does it on its own. It doesn't wait to you to tell it. If it did that, a lot of people wouldn't breathe because they're trying to walk. We know people that can't walk and chew gum. I'm not pointing fingers at nobody. I'm just saying we know these people. But it's an automatic system. The body doesn't have to tell you to blink, or you need to constrict your pupils when the light is turned off or turned on. Come on, we got that. We're good for that. the muscle and the body coordination is also controlled by the brain. Y'all can remember it is controlled right here. This is the lower part of the functioning brain. That's where everything tells you to move your arm to, have the functions. That's not the robot. I'm just trying to show you. But that's where the different body is controlled. The cerebrum is divided into the right and left hemisphere. So it's just like when I'm looking at your abdomen, when I'm going to assess it, I'm going to use the left, upper left quadrant, or the left lower quadrant, the right upper left, the upper right quadrant and the lower right quadrant. So it's the same thing about the cerebrum. It each controls activities on the opposite side of the body. So your right is functioning from the left, and then your left controls the right. The middle controls the sensation and movements, and the back processes the sight. So not only are you looking from the front part of your eyes, but it's got to get processed in the back. With that being said, is sometimes you can take damage to the eyes or to the head, and it can affect different parts. So, if you get swelling to the right side of the brain, the left side of the body is going to be affected. Anything that happens into the front, you're going to have the emotional situations to where you may not come out of that, and you may cry a lot, or the anger you get. That's where you get a lot of your PTSD from a lot of the military guys that's come back that suffered through explosions. They get the head impact on the front, and that they can't control their rage or anger anymore. Just parts of the body that were affected. So now, if you know that when you get these patients off of these bad car wrecks, I'm gonna go turn down that loudspeaker when we do it. So when you get these this car wreck and the left side of their body is just numb and it's not doing anything, you know that the right side may be affected, and vice versa for the left. If the right side is not doing anything, you may have good PMS on the right side, but when you go to assess the left side, you just don't feel anything. And it's not, you're going to have a pulse, but the grip, or if I tell you to reach out and grab my finger and I don't move my arm, then you should know which part of the brain is affected. That's what we want you to get out of that. And most people's speech is controlled on the left side of their brain, near the middle of the cerebrum. As you can tell, mine has issues majority of the time, because when I'm thinking too fast, and when I speak, it's like, raw. I don't know what that was, but we're gonna cover it. So, if you have too much swelling, it can affect the speech part. And also think about that when you have a stroke. Sorry, y'all. When somebody has a stroke and you ask them a question, be like, "Hey, sir, how are you today?" Purple. They know that that's not correct. They understand it, but they can't make sense out of it. That is just part of it. So don't be like, "Bruh, do you not know what day it is?" They do. Their brain is just not allowing them to tell you the exact time or date or anything to the correct question. They give you random answers. So the 12 cranial nerves are directly from the brain and run to the parts of the head. Let's see, what is yours saying? So the rest of the nerves join in the spinal cord and exit the brain through a large opening in the base of the skull called the foramen. Look right here. So I'll show you on the next one. Each vertebrae in the neck and the back, two nerves branch out, and that's your spinal nerves. These carry signals to and from the body. Here you go. Here's a picture. If y'all can see it on yours, there's a little opening right here. That is your mangum, your foramen. That's where it all comes out. So I don't think that they're going to ask you any questions on the spinal nerves, but they're going to majority ask you about the parts of the spine, which is your lumbar, your coccyx, and all that area. So you can study up on that. I do remember some of those questions. And always remember, and I tell you over and over because it's something I've never forgotten. If they break their back and their lumbar is affected, and L4 and 5 are damaged, they can't breathe on their own. So that being said, is be cautious when you go to move them. And sorry, I'm getting all these deer camera pictures on my phone and my watch is going off. I kind of want to look, but I can't do it yet. So know what part of the body, if it's affected in certain areas. What also may be having trouble is they could suffocate because they're not breathing because the L4 and 5 are damaged. And all it does is controls the diaphragm upon contractions. So that's the important part about that. So the pathio. So many different disorders may cause a brain dysfunction and may affect the patient's level of consciousness. It says speech, voluntary muscle control. The brain is most sensitive in oxygen, glucose, and temperature levels. A significant change in any one of these levels will result in a neurologic change. So if y'all have seen the videos of people trying to climb, I just went blank, the highest mountain in the world. They train for that for months before they do that. Well, when they do it, they become hypoxic at Mount Everest. Thank you. So when they climb this, they get past a certain point, several thousands of feet, that they become hypoxic. I thought that was a bunch of crap for a long time until I went to Afghanistan my first time. Mississippi's roughly, let's just say for easy math, it's a 0. We're at sea level. I show up to Afghanistan at 6,000 feet above sea level. Bruh, at the time, this skinny kid had major trouble breathing. I couldn't breathe right. I just had no energy. I was very tired all the time. I had, for the first week, I was just not making any sense. I don't know what I'm doing here today. Sorry, I was supposed to say my name. Once I found out what it was, and then as my body got used to it, worked fine. When I came home, boy, talking about a different world, I was able to breathe better, had more oxygen. Well, I actually started training with a altitude mask. So that being the case is when I was home and I was on the gym, even with just regular working out, I would always wear an altitude mask. So it would strive my body of oxygen, and I didn't work out with just 6,000. I would work out with a negative of 12,000 at an altitude of 12,000. So I stayed hypoxic during working out. So it's the same thing when you go to this. If you notice that there's this massive change of oxygen due to them being hypoxic, well, we can fix that pretty easy and pretty fast. And what is the tool that we carry that's going to allow us to see this and to do something with? What is that? Somebody tell me. While y'all are doing that, I'm going to look at a deer picture real quick. So we are going to look at their SpO2, but what we're going to use is, that's a fat deer eating a lot of my corn. Whew. So what we're going to use is the pulse ox to get that. There you go. Good one, Josh. So we're going to check their SpO2, but we got to use the pulse ox to find out what it is. So a lot of these climbers, we actually carried them on us pretty well. We actually had a deal that for the first week you came in country, no matter what happened or where you lived, if you were from Colorado, it didn't really bother you, but you weren't armed for the first week. So if we looked at that, we would take them and we would still work out with them and all that, but we just wouldn't allow them to be armed for their first week. And that's the majority of the things that happened over there. Iraq was a little bit different because it was hot all the time and it was deserty more than Afghanistan was. You don't really believe that it snows in Kabul, but I can show you pictures of 6 inches of snow in Kabul. Temperature is going to affect you a lot of the times too for the brain. If a person gets too hot, they can actually have seizures, like we've known. Everybody knows anything higher than like a 104, you be careful because they can have febrile seizures. The body can shut down and just it's in melt mode because the body's just too hot. So onsets of headache. When we say I have an onset of headache, not talking about COVID, what is something that we're worried about that comes along with the headache? Anyone? Bueller? Stroke. Good job. Appreciate y'all. So yeah, and you can have swelling. So to give you an idea, I suffer from migraines. Matter of fact, I gotta take my injection tonight. For the long, like I would average up, and this was written down and noted. I had about roughly 35 to 40 migraines a month that were on recorded. I got on an injection after a year of documentation. I took 7 MRIs my first year because they were afraid that part of my body was not functioning right and that they were checking me for everything in the world. But they wanted to make sure that I wasn't potentially in stroke mode, that something was wrong with my brain or wasn't swelling. And they needed to check my pituitary gland to see if it was actually even producing anything. They checked me for all this. But we want to know, make sure that headaches aren't caused due to strokes, that there's not a particular clot going off. They have to realize that. If nobody's ever had a migraine, God bless you. I think I don't like you, but I'm blessed. I think that's a blessing. People do get your tension migraines because of stress, traumatic events and situations also trigger those. If you live in the South down here, I don't know where a lot of you live, but if you live in the South, you know what a sinus headache is. You know what a heat headache is. Most of the time, your heat headaches are caused due to dehydration. So you've been working out in the sun. Like Sunday, I worked on a tractor. I bush hogged for 7 hours. The last hour, my tractor got stuck, and it's still there. It's still in a natural spring that I found that we didn't know we had. You get that dehydration headache. Well, that's your fault. I thought I was having another migraine coming on because of the way it felt. So you have to understand your body. You have to listen to your patients. Do a good assessment: who, what, when, where, and why. And why did you call me now versus 2 hours ago? Well, it wasn't hurting then, okay? And then you do a full assessment. Can you do this? Can you say, can't teach an old dog new tricks? We say certain things like that because stroke patients aren't going to be able to do that. They can hear you, but they can't process it. So little phrases like that will trigger, for you to realize, okay, well, this patient's having a stroke. We need to activate it quickly. Let's see, we talked about that one. Tension headaches are caused by muscle contractions in the neck due to stress. Woo-wee. Yeah, y'all never had stress headaches. I don't like you either, but that's the most common type. Let's see. Most of them are dual. People feel like they're squeezing their head. I can tell you, after so many years of figuring it out, rubbing like your eyebrows right here and you just squeeze them. On point, bro. Go try that. Laying on ice packs, that does help. So if you're transporting a patient and you have the regular little ice packs, you can bust them, get them cold, lay them to the back of the neck. Yeah, we need to cover them, but that is some of the good things that we come across that has realized to help patients is cold to the back of the neck will help block those, and then that way it helps control the nerves to the back of the head, the blood flow, because that's really what's blocking it. Let's see. They usually do not recall medical attention, but I've transported people with headaches to the hospital. It is a debilitating condition to them. They're the ones that's going to have to deal with it with their insurance, not us. We just may think it's stupid, may think it's uncalled for, but that's not our decision to make. We just need to transport these people. I'm so sorry. We need to transport these people and still treat them with the best, because as soon as you stop doing an assessment, you're like, Fred's just having a freaking headache and I got to sit here and do this, you may miss that stroke diagnosis. Or when you come back to the hospital and they be like, hey, I don't know if you knew this, but Fred died because he actually had a stroke and we took your word for it. They'll do it that way. They'll blame it on you. So you be careful for that. Migraines also be changed by the blood flow and the size of the brain and the base of the brain. So you can feel these contractions, like when the blood beats coming from the heart, going to the oxygenated and all that. You can feel them in certain places, so you get that palpation sensation. The pain is usually described as obviously pounding, throbbing, and pulsating. It's because they pound because of the beat of the heart, and then the pulsating is also because you can be associated with sounds, bright lights. Mine is a bright light situation. Let's see, last rotation, I had a really bad headache over the weekend. I turned all the lights out in here. I turned my computer screens. I still worked, but I turned them all black. I had a little work lamp over in the corner. When people come in here and during the daytime, they're like, Doc, you asleep? What's the deal, bro? You good? We just need to know. So little things like that. You can get very nauseous. You can get sick to your stomach. You can vomit. They do mess with your eyes. That's the reason why I get light sensitive. My mother-in-law has, I can't remember the name of the headaches, cluster headaches, and hers, she has had one for the last 7 months. She's tried from Botox to, I think I jokingly say she's tried from Botox to cocaine and nothing's working, but I don't suggest you trying the cocaine because it's not what I'm trying to tell you to do. But migraines, they're horrible. I promise you, they suck. So if you've never had one, count your blessings. Sinus headaches, man, we get those a lot out here. A lot of my my crew out here, they complain of a lot of the same things. We are a very cold environment out here. I think the natural air is set on like the low 70s, maybe 70 degrees. A lot of the guys, 90% of them, go hump butt all day long, work as hard as they can outside, and then they come into this cold environment. And it's the same thing at home. Is we get these just the sniffles. Dude, I agree with Joe. The terrible headaches is absolutely awful. So we get the nasal congestion, the drip, the sore throat out here a lot. Now, I will say, due to everybody now knowing that if you say that, that's a COVID symptom, they send you home. So a lot of the guys don't say that. It is very cold in the living quarters. I still sleep with the fan, but I'm the only person that sleeps on our living third floor. It's different out here. So the congestion issues is a lot of people treat themselves out here just because they don't want to get sent home. It's just the way we are in the world right now. So calling an ambulance for nasal drip is not a 911 situation. But what you got to understand is a lot of these people we deal with don't have insurance. They maybe are a rural area. They don't know what a primary physician is. They only see the doctor when they're born or they die. So the ER are some of these patients' physicians. Like they're like, oh, that's my family physician. No, he's an ER doctor, not a family physician. So those are some of the things that you need to understand when you guys probably treat yourselves. I know a lot of guys come out here and's got an arrayment of medication. I don't ask, I don't care. It's not my, unless you come to me. So serious conditions include headache and symptoms are hemorrhagic stroke, brain tumor, and meningitis. Meningitis being the last, probably the least most one, because they rule that out pretty quick. Is saying, hey, have you traveled anywhere out of the country? Well, not a lot of people are traveling right now just because COVID's the end of the world, but our country is still a beautiful place. So meningitis is not real big inside the U.S., but at the same time it is more known to happen in some third world countries. So you come back from a third world country and start having these headaches and symptoms periodically, they're going to treat you or test you for meningitis. Hemorrhagic stroke is also very, most of the time, what they name down for, and they get the headache symptoms. So you have to do your assessment pretty well to make sure that you're not missing a stroke symptom. And if you happen to catch it and you're able to diagnose it, it looks really good on you. So you can also call stroke CVAs. They may dispatch you to a CVA in progress, and you're like, why am I going to CVS? No, oh, CVA, my bad. I've done it. That's okay. So all it's doing is interrupting the blood flow to the area of the brain. So it shuts. It's like turning a switch, and we're just going to shut that off. If you shut that off and you start noticing the stroke, you're going to lose brain functions. That's in the latest part. You have to pick up on some of the signs like the droopy in the face, the inability to talk, carry on a conversation, answer weird questions. That's kind of your telltale signs leading up to it. The brain functions and the loss of brain functions is mainly because it's been blocked from blood flow for so long. That's what the worst case is. Now, there's two types of strokes. You can have your ischemic and your hemorrhagic. Pretty sure we dive off into yep, we sure do. So the most common, as accounting for 80% strokes, is your ischemic. They do result from thrombosis of a embolus. Symptoms range from nothing at all to complete paralysis. And then if y'all know what paralysis is, if you don't, you're going to have to Google that real quick because I want y'all to learn something. Arteriosclerosis in the blood vessels is often caused at this point. So you can have, weakening of the blood vessels, and then the clot being so big that you can die. Here's an illustration right here. Shows you where the clot's at. If they're able to do, I don't know what the little heart symbol in the center of the head is, but I'll give them credit. It's a decent picture. So you can see where the clot is at, what the clot is doing. It's blocking functions of the brain. Now, looking at this, what side paralysis should we expect of our patient?
Left.
The left side, because you're looking at the patient's right. Again, if you're looking at the screen, the patient's also looking the same way. So it's pretty easy. You knew that was on the right side. So you should expect paralysis upon the left. I get some water. I was hoping that would help me not yawn in y'all's face. So you can see arteriosclerosis is damage of the wall. So you're probably not going to get that back. That function right there, if it's greater than the 3-hour window, you may have issues walking. You could have issues in just moving in general. You'll have to excuse me because the picture that I just got is a really big deer that I've been looking for. Yep, that's him. Sorry, I just had to. But anyway, so you're not going to get it back. You're going to lose those because of the cell has lack of oxygen. You're going to miss the the block of, you don't have any more blood flow to that area. So it's dying, and the only way to fix it is you got to try to get this person to a facility so they can get the clot buster. All right. So hemorrhagic stroke, this only accounts for 13%. So with 13%, it's still a low number, but you're gonna see it pretty regular. These happen. So this is what you're gonna see, these strokes, but you're gonna see your ischemic stroke more than the other. Figuring out which one is gonna be there, it's not. We're not physicians. I don't expect you to figure out which one is this. Is it ischemic or is it hemorrhagic? I don't know, but it does result from bleeding of the brain. Now, that being the case, that can be from a traumatic injury. That can cause swelling to the brain. Cerebral hemorrhages are often fatal. Yeah, because I mean that's the swelling. I mean, yeah, we know that. People at high risk are those who have high blood pressure or a long-term elevated blood pressure that is not treated. So the ones that are like, I'm gonna die of something one day, well, you could, but it can be fixed. Your life can be prolonged, and you can live at the best with just taking a tiny little pill. Just treat it, and also some changing your diet and your food. So little things like that can help you keep from getting these hemorrhagic strokes. But a lot of people just, they don't, it's a silent killer. They don't really know. Like, oh, well, you know, Fred died in his sleep. Well, no, he really didn't. And right now you can imagine how busy these morgues are on getting these, all these autopsies done, that they may not know what really killed him. And for a while, because I know right now, if it's a COVID related death, they're not doing autopsies because they're overwhelmed with it. So here's you an aneurysm. It's a swelling of an enlargement of the wall and the artery resulting in a defect weakening. So these can blow out. If you see it's all swollen right here, that is a very bad picture. And that's normally not what it looks like. You would normally see it over this right here. So that is what they all do in there. They can go and put stents in those areas too. But they can block, they can go around right here. Sometimes the clot buster will work to go in there and fix that to where they can try to pull it out. They can pass it through. So it's pretty neat. Like, if you ever get to watch one of these types of surgeries, when they bring them in there to the stroke room, if you just happen to know the right people, they can bring you in there and let you watch them. It is pretty jam up cool. I've got to watch 2 of them, and they literally were able to go in there and get the clot and pull it out, and the patient hadn't had any issues after the fact. I thought that was pretty jam, to be honest, but cool. So a TIA, now these stroke-like symptoms do go away in less than 24 hours. And they are, there's yours right there, number 2, they are warning signs of larger strokes to come. So don't ignore them. If you get called for that and then you realize, be like, oh God, well, I don't know what's going on. Why is it the situation that we're seeing? Why is it coming and going? You know, I saw him just the other day and he didn't act like that. So what's the deal? Well, it's because it's a TIA, and you're gonna see it and it's gonna go away, it's gonna come back. But these need to be treated just as important as every other stroke that you go to or any other medical call, because you're not knowing what's coming down the road. We don't have this magic little tool in the ambulance that can be like, this is what's wrong with you. We don't know, so we're gonna treat them as they're having a stroke. It says all patients with TIA should be evaluated by a physician When you do this, try to keep their head elevated higher than the rest of their body, depending upon where this the stroke is. It's happening. It could affect or bust the clot to move it any further. So be cautious when you adding or moving them. Just another thing to be careful. Signs and symptoms of a stroke. We know this. I don't know. There's a commercial in my area that always talks about I'm having a stroke. You're not gonna speak to me. I'm having a stroke. So those things like that. If you've heard those commercials, they push those out there. AHA does about facial drooping, sudden weakness, and numbness in the face and arm, leg, or one side of the body. It's 99% of the time going to affect one side versus both sides. Decreased or absent movement and sensation on the side of the body that's affected, and you'll have lack of muscle coordination. Their balance will be thrown off. You'll have they may have fallen because they're like, oh, I just lost my balance. But why? Like, is there a reason behind? Like, that gives you an investigation time to figure out what's going on. So sudden vision loss in one eye, they may be blurred, they have double vision, they may be like, oh, every time I open my eye, I get dizzy because everything's blurred. Like, do you have like cataract? Do you have a contact that you're missing that you now have obviously found? Those are some signs you look for. You, like I said, ask simple questions. Sir, I'm gonna say something. I would like for you to repeat it back to me. You can't teach an old dog new tricks. Or simple as saying, who's the president right now? I don't care what side of the country you live on, what side that you voted for. 99% of us know who the president is, unless you just live 100% off grid and you're just a mountain man. You're gonna know. Decreased level of responsiveness is because they're zoned out. They have a glassy appearance to them. They don't know what's going on. When you ask them questions, their speech is a little rough. It's I don't know. And you're just like, I want to talk for you because you're thinking in your head, okay, we got to do this, we got to do this, and it's like a sloth, like them. I don't know if y'all watch Disney's or not, but it's like going to the DMV where the sloth is in charge of running the DMV. It's like trying to ask questions and you're just like, oh God, we're wasting important time. Just spit it out. Oh shit, he can't. All right, let's go. And then when you get in the ambulance, they're like, Fred. And he's talking about, well, you asked him 5 minutes ago what his name was. You just give him time to answer it. Things like that. So there's your signs and symptoms. Let's see what mine says. Aphasia is difficulty expressing thoughts or inability to use the right words. Expressive aphasia, or difficulty understanding spoken words, and that's receptive aphasia. You see the slurred speech, sudden and severe headaches, confusion, and the dizziness. Those are all some of your signs and symptoms of a stroke. They all should not be ignored. A lot of these you can see are not going to be more of a COVID related, because a lot of the things that you see is like, oh, he said he was nauseous and vomiting. Well, yeah, it's not a COVID related, maybe because he ate something that wasn't well cooked. So don't just get your blinders on when they start answering some of the questions. If it's really hard for them to answer you, maybe it's okay to ask family, bystanders, and all that. What is his normal state? Well, he talks like you and I, and he's like, no, I don't, that right there is because the speech is slurred, it's delayed, and something's wrong. That's not normal for him. The combativeness can get pretty rough. They don't know what they're doing. And not being disrespectful to them, they don't know what it all is happening. They're well aware, but they can't control it. Worst case scenario, they can go into a coma. They can have severe restlessness. They kind of move, they shake. It's it's the early signs that you see these things. The weakness is going to be one-sided again, and it might be also because both sides you see some weakness in. It's because maybe they sit there and shake, not seizure-like, but they'll sit there and just shake and have tremors to where they've burned all the sugar and the energy storage in their bodies, just burned it up, and they're just like, I can't do nothing. That's fine. That's you need to understand what these symptoms are and treat most appropriately. Stroke in the left cerebral hemisphere may cause aphasia, and that's the inability to produce or understand speech. Speech problems can vary widely. Strokes that affect the left side of the brain can also cause paralysis of the right side of the body. So you see where it's automatically telling you that one side is, going to be worse than the other. If that's the case and affects the right side of the body, well, I mean, you know what's coming. And that paralysis may not be reversed. Let's see here. We'll go 2 more slides and then I'll take you a break. So the right hemisphere, strokes that affect the right side of the brain can cause paralysis of the left side of the body. Talked about that a minute ago. Y'all get the difference in this, what side of the brain affects the body. Usually patients will understand language and be able to speak, but their words may be slurred. Already told you that. Patients may be obvious to their problems. The symptom is called neglect. They're not wanting to understand what's going on, or they can't comprehend what's going on. May neglect certain parts of their vision. Neglect and lack of pain causes the patient's delay seeking help. So just because it doesn't hurt, I don't need help. I'm, cut my arm off. I'll be fine. We'll keep going. Well, that's not how we do it. Maybe as you're just walking through and you speak to somebody and you're like, whoa, what? They're sitting by themselves, specifically nursing homes. It happens all the time. You may be able to walk through and realize that the patient is slurring their words. They're very slow to move. You start asking questions to the nursing staff that possibly is new onset or is maybe their demeanor all the time. So bleeding of the brain, we know it's going to cause swelling because there's nowhere for that to go. Just because I may be bleeding on the right side, it doesn't give my body enough time to absorb it and push it out. So it's going to continue to bleed because obviously there's a busted vessel, may have some trauma to it. What's it say? May be caused by the bleeding as a compensatory response. A trend of increasing blood pressure is an important sign, as the body must increase the blood pressure to get the blood to the brain's tissues. Significant drops in blood pressures may cause the patient to get worse. So if you're treating somebody and you notice that their blood pressures are either super high or they get low in certain situations, that's them compensating. But you need to understand what the change in the blood pressure is going to cause. You can have the cushioning effect, where the blood pressure start to get from here to they start balancing out. You're going to have some neurological effects there, to where the bodies are going to start shutting down because they need to shunt it to other areas. Major blood losses, because let me go ahead. So in a trauma, if I have a head trauma, I can bleed out of my arm and I can bleed out of my brain if the skull is fractured. But I don't have to have that happen if I'm, I don't have to have a spot to be missing to bleed out and still be an injury. There can still be an injury in the arm and bleed out, but we're going to see it because it will start swelling. Well, it may not affect the areas here on your skull because it's pushing against the skull and it's combining pressure against the brain. So the swelling and the leaking of the blood is the problem, but we won't know that unless we monitor their blood pressures. And we realize, we're like, wow, there's a pretty drastic change in these blood pressures. Something's up. What's going on? So like I said, it could be that bleed that you're recognizing because you got a trend of blood pressures. When we were talking about vitals and all that the other night, and I was telling you may have to do it and pick out some to write, And you may just have to do a supplemental blood pressure sheet and say, like, when your report asks for it, be like, see a supplemental blood pressure list. That'll go from there. Let's take 10 minutes. I'll see y'all back at 7:35. Anybody got any questions real quick? We want to talk about anything? This is a small chapter. There's not a whole lot in here. So it should be simple. Any questions for you guys? All right. Well, I will see y'all in 10 minutes. Let's make that 9:36 now. See you in a minute. All right, folks. I don't know about y'all, that was like a fast 10 minutes. Whew. All right, let's get this back going. All right, so conditions that may mimic strokes. So we talked about your hypoglycemia, postictal state, subdural and epidural bleeding. So the postictal state is a seizure. That's where they are calming down. That's after the seizure has taken place. So they are very sluggish to answer. They're coming around. It's like when you reset your computer's a little slow to get running until everything processors are up and going. So that is part of it. So when they're in the postictal state, some people in the past have said, oh, they must, well, we didn't see them seizing, but they must have had a stroke. Well, you can have seizures and not visually be seen seizing. So that's something that to keep in the back of your mind. Subdural epidural bleeding can cause swelling of the brain, which we've already talked about. So that can be issues also for the stroke. There's a picture right there of the epidural hematoma that they can be added in different places. You can see where they've had trauma to the head. It can be right around to the dura or pushing against the brain in different places, which is going to turn around and cause some deficits to the body, because we already know that certain damages to certain places are going to affect the speech, the eyesight, because if it's to the back of the head like B is, where A is, it could be that's the right side of the brain. So depending upon what function is damaged, they get that back, or there's signs and symptoms telling you what potentially has happened. So seizures, that is a neurologic episode caused by a surge of electrical activity in the brain. In the United States, it's estimated that 3.5 million people have epilepsy. Seizures are classified into two basic groups, generalized and partial. So a generalized, we used to hearing them, you'll hear a tonic-clonic seizure. So those are your general ones. It results from an abnormal electrical discharge from large areas of the brain, usually involves both hemispheres. So they're typically characterized by an unconscious and a generalized severe twitching of the muscles that last several minutes or longer. So a tonic-clonic seizure is generalized by twitching of the muscles that last several minutes or longer. So absence seizures does not involve any change in the motor activity. This is characterized by a brief lapse of consciousness in which the patient seems to stare and not respond. So, give you an idea. You guys currently, I don't want to say what you do, but probably most of the time when I'm lecturing off and going off into different space, you zone out. We're all grown-up folks. We have all these other things going on and paying attention. But if we were sitting there and I was to reach out and call your name, you'd be like, oh, hey, what's up? What's going on? You zoned out and you didn't have a lapse of consciousness, but your focus was on things else. So those are types of seizures also. So that is an absence seizure. So your partial or focal seizure, those are focal onset awareness seizures. No change in the patient's level of consciousness. They may have numbness, weakness, dizziness, visual changes, or they smell weird things. They're like, oh, who put what in my mouth? That may also have some brief twitching, but most of the time, that's the one that's going to have majority of your twitching, is the true generalized seizure. That's where you're going to see the twitching and the shaking. So the patient has an altered mental status and does not interact normally with his or her environment. Results from abnormal discharges of the temporal lobe of the brain. Other characterizers may be lip smacking, eye blinking, and associated isolated jerking. Patients also may experience unpleasant smells and visual hallucinations, exhibit uncontrollable fear, or perform repetitive physical behaviors. Your focal seizures. So those are so what I would recommend is learning your generalized seizure and knowing the difference between your partial focal and focal. It's the same, but you want to know the differences. There we go. They can be visual changes and hallucinations. People with a history of seizures recognize their so they recognize that these seizures are coming on. A lot of times the ones that have these types of seizures, these patients can have, if they're severe enough, they can have a seizure dog. They can have these alerts where it notices the body starts to twitch a little bit, blood pressure may increase, heart may go off. They will have triggers that will make them say, oh, to where they know that these seizures are taking place. Some of your generalized seizure is characterized by sudden loss of consciousness followed by chaotic muscle movement and tone of apnea. May exhibit bilateral muscle movements characterized by a cycle of muscle rigidity and relaxation. And most of these do last about 5 minutes. And just remember, during seizures, you can have a brief lapse of incontinence, which means they're going to either pee or poop on themselves. That is very traumatic for the young kids that have these happen because they don't want their friends to see them like that. So I highly recommend putting a sheet over their body so they can, not like they're dead, but just to cover their lower part of their body so you can keep their dignity. They're having to remove these kids from a school or a social setting. That way everything's left on par and good to go. So the absence, the formerly called a petit mal seizure, may last for just seconds, after which the patient fully recovers and only a brief lapse of memory. So they know something happened and they're like, well, did I have a seizure? Because they know that things are going on. So petit mals you classify them a little different now. They're not going to be like, oh, what type of seizure is that? You just didn't know that? It's not my job to know all these seizure types and classifications. It's my job to help stop it or provide pre-hospital care. So I'm one of those that I'm just like, all right, sure, let's just get the patient some medication and the treatment in the right facility. And now we can take this patient off of my stretcher and I can go save the other ones. Status epilepticus is these are the ones that last longer than 5 minutes. That is the big difference. Timing, knowing how long that they've been going on is a very important thing because it helps you diagnose and to figure out which ones are which. Seizures that continue every few minutes without the person regaining consciousness or lasting longer than 30 minutes. And reoccurring or prolonged seizures should be considered immediately life-threatening. We carry medications that can help stop these. I have given enough medication to sedate a horse and been giving different orders to do more upon certain seizure patients because we just couldn't get their seizures to stop. I have air transported a seizure patient because I was unable to secure an airway. This person seized for 5 minutes, took a 30-second break, and they seized for another 20 minutes. So that tells me that they're not breathing appropriately and they're not having enough oxygenation going on. So I was unable to do it, and that's what was able to me to justify sending them by air. Air also carries a lot more narcotics and has a faster route of travel. They don't have a whole lot of traffic up there if y'all haven't noticed that. So it's better for the patient to get them who, what, when, where, and why as fast as they can. All right, so there's some causes of seizures. I'll let y'all read that for a second. You should also see that in your book of different common causes. Here's you another one. Oh, I didn't go. So epileptic seizures, they usually can be controlled by medicine. So there's a lot of the ones you'll see. A lot of the ones that I'm used to dealing with is your Keppra, your Dilantin, your phenobarbital, your Depakote, your Topamax, and your Klonopin. I don't really get a lot of your Tegretol. I haven't seen that in years. Not real sure if that's just something that is depending upon the physician on what they like. But you know, it's a lot of those medicines too are given by trial. You have to figure out which one works the best for the particular patient. So it's a trial. We got to figure out which one is going to be the best for you, and I need to know the dosages. So it's a trial for a hot minute. So here's why I want you to recognize them. Recognize if a seizure is occurring and whether it is episodes differs from previous ones. Recognize the postictal state and the complications of a seizure, and identify the problems associated with the seizure. So the postictal state is once a seizure has stopped, the patient's muscles do relax. They become almost flaccid or floppy, and then the breathing becomes labored. May be characterized by hemoparalysis or weakness on one side of the body, resembling a stroke. Keep that in mind. The postictal state is most commonly characterized by lethargy and confusion. If the patient's condition does not improve, you should consider other possible underlying conditions. The patients are going to be very confused, and a lot of the times, if it's a first time that they've ever seized, you're going to walk into their home, potentially their bedroom, and they're going to look at you and be like, who the hell are you? Why are you in my bedroom? Now, they're not going to talk like that because they're still processing things from the traumatic event. A lot of times, you have to persuade them to trust you because they're scared, they're nervous, they don't know what all's going on, and they just have to figure things out. So it takes them a hot minute. So you just know that going in that you're just not going to walk in and save the day, that you have to build that trust and then be like, hey, well, come with me. Let's get you to a hospital so we can figure out what's going on. A lot of your first time seizures or the seizures that happen once in a blue moon aren't the medicated ones. Obviously, your first time ones aren't, but those are the most traumatic for those patients and the ones that are around them because it's not expected. I don't know what's going on. I don't know why that you're seizing. So that it's traumatic to the entire group. Seizures do often have feigning typically occur with the patient standing. Seizures happen in every single position. Now, just because they fainted doesn't mean that's their postictal states. So recognizing the postictal state versus a stroke is important because you need to treat it correctly. You can't give a stroke Valium to stop them from seizing because it's different. You're trying to give a patient that's got a bleed some Valium when that's not really what's going on. So recognizing the difference is the important thing. If there's nobody around, it's harder versus somebody's be like, oh no, I watched him seize for 5.5 minutes. Those are easier to recognize. I'll tell you now, on a seizure, if your paramedic is slow, if they're just like, oh yeah, we're just gonna transport, try to persuade them without trying to be bossy. but tell them, hey, don't you want to get an IV on this patient while we're sitting still? Or is there a reason why you want to hurry up and go now versus, make it, a delayed response? I just want to learn while I can. And see what they say. IVs are highly important to your seizure patients because if they start seizing on the way to the hospital, I have a line. I can give them medication. And the important part is it was established prior and tied down prior to transport, which means all I got to do is draw the medicine up. Bam, good to go. This computer. Altered mental statuses. So sometimes we may think that we all have altered mental statuses, or we know somebody that's always altered, but that may not be the case. So aside from a stroke and seizure, the most common type of neurologic emergency that you will see on the streets, period, is a altered mental status. That's it, and it can be from a neurologic issue, from a brain defect, or drugs, alcohol, anything like that. Some of your causes for your altered mental status is written right there: hypoglycemia, hypoxemia, intoxication, delirium, drug overdose, and unrecognized head injuries. You see a lot of your unrecognized head injuries from somebody that may have been involved in a low car MVA. Everybody's fine. We're going to be good. We could, have a good time and leave. Well, they realize that when they go home from these good times and maybe they hit their head or got slammed up against the wall or something like that, and then they get home and they start having the seizure, or they're just not acting normal, is when we get the phone call to come be like, hey, Fred's not acting the same. Something's wrong with him. We need to figure out what's up. Well, the delay of the time is the hard part, because now who can tell me what happened to Fred? How long ago? Fred's the only one who can tell you. You still want to treat that. You'll check a sugar, you'll do all the fun stuff, you'll transport them to the most appropriate facility, because you just don't know. We don't have an idea of what's affecting them. The brain infection, I'm gonna say that's gonna be like maybe a 1%er, if not lower. The body temperature abnormality, so that's gonna be because of an infection or let's say COVID. Let's say they just got a regular flu-like fever and their fever spikes. Well, that could cause them to have the altered mental status and change in their behavior. Overdoses or poisonings. Well, everybody sees these traumatic events when people take these bad tryptoid medications and they're walking around like zombies and bending in half and picking at their skins. That really happens. I don't know. That's not just TV, y'all. I couldn't tell you how many crazy folks I've transported that are having a bad trip that just Narcan don't work on. There's just some things that those need to go to a facility, and if you need mandate that they go, it's for their safety, and that's when you can basically force somebody to go. We have to call med control and get that approved and all that weird crap, but we can make them go to a facility and make them be seen. So that's we can't just make Joe Blow off the street unless the med control understands why we're pushing for that to happen. But if it's unknown and they're by themselves, we can most likely sell a story to them as a physician to where we can get them to go with us. On scene size ups, what are we doing? Make an early determination what's going on. Have a game plan. Figure out what you're going to do. Am I going to stay and play? Do I need to start an IV in the house or in the car, and then just hep lock it and move them on? Know your game plan depending upon what dispatch has told you. Again, we've talked about dispatch. They can only tell you so much. So if they don't give you any information besides just, you're responding to such and such for an unknown, maybe they haven't finished MD in the call, or little things like that. So be careful when you go to these scenes of the unknown. Just make sure that you got a 360s, of your scene potentially going on. Keep that in mind. Follow standard precautions: gloves, eyes, mask. That is have to be on. Consider the need for spinal mobilization. If you see this patient, and you have a ladder leaning against the building, assume that they fail until proven otherwise. You don't know. If you potentially move this patient, you could cause other harm and injure them worse. So if that's what you need to do, is just C-collar them, get them on, and move them over to the stretcher, and keep them, and let somebody else that can x-ray them and make those decisions. That's okay. Most agencies now, unless they complain of head or neck or back pain, they don't get C-collared. Excuse me. They do not get boarded on a backboard in the field anymore, unless now if they have a complaint of it, okay, they will board them and all that. Look for threats to safety. What is going on the scene? What does your gut say about this? Do I need to call for additional support, as in fire, police, or can I go into this area, get my patient, and remove ourselves because it's a safe environment? Going into a nursing home, it's not always the safest place in the world. Some of those folks get a little crazy on you, and they know who you are, they know what you do, and unless you're on a dementia ward, they get a little hostile. Sometimes they hit you with their little walking sticks, but just be cautious. Additional resources. We know that's going to be an ALS unit if you're on a BLS unit, so be cautious about that. Figure out what you want to do. Is this, hey, I'll meet you en route, or I need you here now because I need this, this, and this. Guys, we're going to breeze over this because these are your primary. We've done this before. I'll talk about it, but unless y'all want me to go in depth on how to assess these patients, I'm pretty much leaving this up to y'all so y'all can understand and do your own building of your assessments. You look for any life threats. That is your number one goal, to stop any life threats. If you see massive bleeding, fix it, stop it, block it off. If they're not breathing, head tilt chin lift. If possible, give a couple of, follow your CPR. You need to do some blow-bys or some back valve masks. Rock on with it. Figure out what is needed to do depending upon your patient's level of consciousness. If that being the case, and it states that you feel that this patient is worse than what we expected, transport initially. Don't wait around, and know that you're doing the right thing. Figure out what your ABCs are. I'm not sure what ABCs are, but we're going to go with your ABCs. Investigate the chief complaint. If they tell you my hemorrhoid's acting up, but they can't tell you time, date, place, or person, let's ask the nurse or family members, what exactly did y'all call this for? Because I would like to help him the best that I can, but I don't know if I'm understanding him exactly. So ask those questions. If nobody's around, do a quick look for explanations of what possibly went down and why I'm here. Obtain a sample. If the patient is able to give you that information, then go forth and rock along with it and make life easier on yourself. That is something that's needed. Try to determine the events leading up to the incident. Why are you here right now? What can I do and how do I fix it? That's what I want to know. Your sample, can anybody tell me what your sample stands for?
Signs and symptoms, allergies, medication, pertinent, history, last oral intake, and everything else.
That's correct. When we go over your chart method on how to rate charts, I do a D chart, and just to kind of go off of that, and it's dispatch, chief complaint, history. T is for treatment. A is your assessment. Sorry, R is for treatment, and T is for transport. And I like to put an E at the bottom in case I can give a very good explanation of the environment and the scene. That's why I do a D charty method. Trust me, we'll go in that in depth because y'all will have to write me a couple of charts. Just to let y'all know that. Vital signs. Why are our vital signs important for our patients that we're taking care of?
Vital signs can potentially be life-threatening, so we need to know whether or not they're changing.
Yes. So that gives you your baseline. What is, if recognizing a life-threatening event by their vital signs, that is correct. That gives you, if you know that, be like, oh God, they don't have a blood pressure. It's really, really low. What's going on? You know that something is affecting their flow, their heart, their motor is having issues. We want to check that. Does anybody tell me how often do we check it for non-critical versus critical?
Every 15 minutes. And then critical is every 5.
Yes. So I'm used to 5 and 10. So I know the book teaches 15 and 5. I can't help but say 5 and 10. When you said that, I was like, oh yeah, that's right. I'm sorry. So that was the pause. It wasn't your response. All right. So stroke, we talked about the stroke scales, evaluate the face, arms, and speech. When you get somebody here, I'll show you. Let me turn my camera back on. So when you're looking at somebody and you're evaluating them, and you get them, if you think that they're having a stroke, get them to smile at you. And if you see the droop on one side or the other, that gives you a hint. Obviously, I'm not going to be pulling it down. Let them smile. Say, show me your teeth. And then you say, hey, do me a favor. Hold your hands out just in front of me like this. If this is all they can do, then you know that they're having some type of stroke. The left side's affected because my right arm is drooping. Anytime that you get a chance to go to a stroke class, sometimes your state EMS will offer them. You're not going to get anything in person right now. But if you recognize that they offer free online training and you can attend a stroke program, please do. They are wonderful. The Cincinnati pre-hospital stroke screen is probably the most used out there. It is a lot of, there's a lot of different places that have adapted to the Cincinnati. Like Miami's got one. They're the bigger stroke places in the country. And you use your GCS. I don't want to tell you how to do the stroke severity scale because it's complicating, but use your GCS to where you know what's the highest number we can get on a GCS. Okay, let's try this. What's the lowest?
16? Is the highest 16? Hang on. Or is it 15?
Here's somebody. I heard somebody that's really low. Joseph, was that you talking?
I was just saying, I'm not sure.
Okay, all right. Yes, so 15 is the highest, 3 is the lowest. You can be dead and get 3. So see, no matter what, you are important because you still get a 3, you don't get a 0. I'm just picking. That's a joke. So your highest is 15 and your lowest is a 3. Anything less than 8, you intubate, which, no, obviously you can't, but you can put an oral airway in. a king airway that you can put all those airways down, and you can bag these patients. So if you notice that the patient is very lethargic, they don't really come around for anything, and you do a good assessment based upon what your protocols are for your agency. If it's less than 8, you intubate. Okay. Here. So there is the be fast. You look at the balance, eyes, facial droop, arm drift, speech, and time. Those are something that will help you write your report based off of those findings. I don't know that one, so I can't really tell you. But if you buy a really good field guide, they have these answers in there for you. They have these little charts, and they're like little tabs. They look like they're probably yay long, probably about yay thick. It's an array of knowledge in those books. They're very little writing, so if you can't see a whole lot, good luck. Carry it around, make bigger copies. And it helps you get the information you need for a chart. Or as you're writing, as you're going over your paperwork, look back through there, and then you can answer those particular questions off some of the things you've done. They go, okay, yeah, I remember his eyes. One pupil was fixed and one was blown. You know, it can indicate a head trauma. Here's your pre-hospital stroke screen, your Cincinnati one. Talks about the testing. How do you test it? What your normal response is versus your abnormal responses. If on the speech, if can't teach the old dog new tricks, patient uses correct words or no slurs, that's normal. Patient slurs words, uses inappropriate words, and or is unable to speak. So those are yes or no questions, or yes or no boxes. There's the Los Angeles one. I don't know. Y'all can see it on the screen. Most of your agencies probably would prefer which one they tell you. And if you work for some bigger services, have in-house refreshers on things, or Con Ed on their own stroke classes that they teach, may have got the information from another agency out who knows where, or they may be a stroke instructor and they teach you what they want you to use. Here's your secondary assessment for your Los Angeles pre-hospital. You want to know, it's a 2-point question. There's 5. Wow. Oh, sorry. I thought my computer was changing screens. So there's your LAG. I don't know why it's the stroke severity scale, but they're calling it LAG because of their level of consciousness, arm, and then the gaze. That's how you get your different numbers. And there's so many out there. That's why I stick to your GCS, because you should know your GCS, your Glasgow Coma Scale. You should really know that. I'm sure all of you do know that very well. So again, right there, you want to get your mental status. Again, get your GCS, your Glasgow Coma Scale, and that's your number. Then you want to do that initially. You want to reevaluate that. Do you notice any changes? What changed? And document those changes. There's how you get your GCS. I don't know if y'all want to screenshot that, take a mental picture. But you're going to need to know that. I'm so used to it. I can tell you right off the top of the bat what most of the people are just by talking to them. A lot of people think they're gonna automatically get a 15. That ain't true, because you don't know how to use proper words. That's me all the time. So I automatically get a 3 majority of the time. So your reassessment, what I want to assess is my ABCs. I want to make sure that I don't have any obvious bleeding. Reassess my vitals. Make sure that if there's changes, what's changing. Did I do something that fixed it? What did I do? And what was the outcome? If you did something, let's say you assisted in an EpiPen administration. You note that assisted patient with epi administration at 2012. At 2012, here's the vitals. 2017, here's the vitals again. Noted improvement of patient status. Respiratory rate had noted to improve. Patient didn't seem to be as in much of distress. You have to note those changes. I guarantee what's going to happen. You'll laugh. When a patient tells you what's wrong, they'll tell you one thing. You get to the facility, and then the nurse or the doctor asks them what's going on. They're like, "Oh, well, it's my right leg that's really hurting." What? What? You told me it was your left toe. It's gonna happen. They're gonna try to make you like an idiot, but everybody knows that their stories change because they want to get seen fast and move to the front of the line. Just because you come in on the ambulance doesn't mean you can't go to triage and sit in the waiting room for the next 17 hours. It's gonna happen this day and time. So physicians and most patients with suspected stroke, physicians in the ED need to determine whether there is bleeding in the brain. If there is no bleeding to the brain, the patient may be a candidate for a clot dissolving medication. If the bleeding is present, this medication will increase bleeding with distraught consequences. Notify the hospital regarding the last time the patient was known to be without their current signs and symptoms, because that gives you your window. If I knew at 1915 that the patient was fine, well, they found them at 2013 and realized something's not right. You only have 2 more hours to get this patient to the most appropriate facility and get the best treatment for them before that clot is irreversible. Okay. Patients who have had a seizure, they do require a full ALS assessment. They do require your attention. The biggest thing you need to know about when somebody is seizing is protect them, protect their head, make sure that they don't bang their head on the floor, the fireplace. It is, I like to recommend, I will grab a lady's purse in a heartbeat and lay it underneath their head. Most time they got a lot of crap in there anyway, and it's padded. It's just going to be big enough that they can protect their head if they're shaking and all that. Or you can assign somebody to try to hold their head, but you don't want to put them in a compromise where they're doing like this and now their airway is obstructed. So be cautious of that. When they quit seizing, they're going to be extremely tired. Their oxygen levels may be low because remember, they just exerted a lot of buildup energy when they started seizing. So they're tired. They're going to want to go to sleep. It's not recommended that they go to sleep, but sometimes I have let my patients go to sleep when I know that I have IV O2 monitor and I can see everything. But at the same time as every 5 minutes, I'm like, "Mr. Fred," and you reach out and touch him. "Hey, man, I need you to wake up and talk to me for just a second," and pay attention to him, what's going on. If the head or neck is involved in a trauma, suspect spinal mobilization. But again, that is a personal choice. If you think that's what's happened, it's fine to put them in a C-collar. It's better for them to remove it than they need it after the fact. So it's not going to really cause any issues when you do that. If you have to, when a patient is a status epilepticus, that word gets me all the time, clear the airway. If you notice that there was something in the airway as they started to seize, try to locate it. No, obviously don't stick your fingers in there. They may not return and you may be, the 4-finger medic. Be cautious of that. Transport quickly to the hospital. That's a neurological effect. Something is causing that we need to help fix and stop. We can't do that in the field. We need to get them to a facility that can. They need CTs, they need EEGs, they need all these things to help them get that neurological effect under control. You do need to rendezvous with ALS because you need that IV. If they seize again, there's nothing you can do as a basic to stop that seize because you can't carry the medication to give it. If you did, you wouldn't be sitting here in basic school. But hopefully you're training to go higher into your education. You should be concerned about the patient if you have an sudden onset of severe headache, sudden headache with fever, seizures, altered mental status, or the following a trauma event. If you just get called and be like, "Oh, I've got this splitting headache and I don't know what happened," always ask if they've had a wreck or, been involved in an MVC in the last 24 to 48 hours. That could be your sign right there. Have they been involved in any type of trauma that may have struck their head, baseball accident, got hit at the baseball part by a ball, could have caused that hematoma in the brain and now it's starting to swell. Ask questions to figure out what's going on. Do they understand what I'm saying and what is their mental status at the time? Did they call us? Did a friend call us? Did family call us? Something. Why, sir or ma'am, why did you call me today for Mr. Fred? What's going on that concerns you to call 911? Well, he's got a quick onset of a headache. Okay, what's happened for him to have this headache? It's okay because he's a new patient and you got to figure out what's going on. Migraine, always just check for any other serious conditions. Check their pulse ox, see what their sugar is, if your state allows it for you to get a CBG. Prick their finger, get that done. Use all the tools that you have the abilities to do. If you can, when you go to transport this patient, turn the inside lights out in the ambulance. Maybe it'll help. Don't run lights and sirens unless it is life-threatening. If you know that you're coming up to the scene and you're able to cut those off early, it's fine. Remember during seizures too that your flashing lights may trigger a seizure and they could go into a seize again. So be cautious of that. Stroke, same thing as a seizure. Your ABCs, your pulse ox, I want to know what their oxygen level is. Can I give them oxygen? Do they need it? Will it help it? Fibrogenic therapy can be given, like I said earlier, in a 3-hour window. 6 hours is the max is for them to go in there with the little bitty tools and pull the clot out. They can plus or minus depending on whom, when, where, and why. There's a lot of things that factor in on that. But 3 hours for the fibrogenic therapy and 6 hours is your max on going in there and retrieving it with the tools. If you can transport to a stroke facility, if it's something that your protocol say that you need to go to the closest facility, advise them that you're coming in with a stroke. And I have been told in the past, please bypass our facility, go on to the next one, unless it is life-threatening, because they didn't have the facility, the capabilities to treat them. Seizure patients may be in postictal state to where they may be asleep. They may be in an altered level of consciousness. They may be coming out from this and be very combative because they're scared. They don't know what's going on. All these people are there and they're like, oh God, I don't know what to do. Okay, that's fine. Take a second. Protect the patient at all costs, but don't harm the patient as you're trying to protect them. Don't tie the seizure patients down super tight on the stretcher. You could cause them during their non-human rage to cause them to break another limb or to break a limb, period. So restrain them on the stretcher, but don't tie them down because they could cause further harm. Again, right there, follow your local protocols. Do not deviate at all. If you need to contact Med Control for some advice, figure out what's going on, I need some help, I need this or that, ask. Pick up that phone and reach out to them. See what's going on. If you're like, hey, doc, I need some help, tell me what's going on. Please provide me with some assistance. I need to know what's going on. Okay, well, you need to do this, this, and this. Get an ALS unit route. They're there for your help. Again, the best thing I can teach you is know your protocols for your area. That always happens when I push that button. Determine the cause if possible. Know what's going on. If you need to provide spinal mobilization, lock it down. put the seat collar, put the backboard on there. Make sure that seat collar is appropriate for them and it fits. If it's an adult, y'all just have adult and pediatric. Make sure it's an adult collar. And even if it needs to be a pediatric, it's okay. I mean, they make small adults, they make big kids. It's not like it's set just for an age limit. If you have to secure an airway where you need to drop in an OPA, or they're struggling to breathe and they can tolerate the NPA, put it in. It's fine. Transport, like I just said, transport to the most appropriate facility, and that it is a stroke facility, if needed to be there. Or if you know that you're like, if I stop at this Band-Aid station, they just going to transport into town, which is 10 more minutes. Are you comfortable with that? And can you provide enough care and justify why you went ahead and passed what your local protocols say? That can cause a lot of trouble at the same time. So make sure that everything, your T's are dotted and your I's are crossed, if y'all know what I'm trying to say. So make sure that your game is on point and you're just not saying like, oh, well, I told my basic to stop. Well, you're both basics. One of you is just in charge of this patient right now. Kind of it, folks. Y'all got any questions? Y'all want me to go over anything? I got your class code on the next slide. If y'all need anything, Rebecca, I'll get to that in a minute. I'll get to there. Does anybody have any questions? Y'all want to talk about anything? Anything at all we can go over. We can discuss some things. I can help you out as much as I can. Y'all let me know. Like the worst time. You sit here and stare at the screen and wait for somebody to type something. We scroll up and down and trying to see if anybody unmutes their mic and everybody's just quiet and you're like, all right, it's just me. All right, folks, there's your class code for the night. Let me type it down in this box so everybody can have it. So it's Sage 457, money sign 42. That's your class code for this evening. Y'all are more than welcome to bow out. If y'all need to stick around and answer some questions, please let me know and I will get your questions answered as fast as I can. All right. Thank y'all. Y'all have a wonderful evening and I will see you guys Thursday. Rebecca, give me just a minute and I'll answer you.
Okay.